We will start move now from refractive to little bit posterior area. I think there is the superior. I think surgeon, they are vitreoretinal surgeon, the most superior people in ophthalmology, right? Dr. Awadallah, I know you like this. Because they can do everything. They can go for glaucoma, they can go for refractive, they can do anything. But cornea, they cannot go to do vitreoretinal anyway. أكيد صح يا دكتور محمد. Okay. Thank you very much. I would like to thank the co-moderators with me here, Dr. Nadeem Al-Hussein, Dr. Osman Mahmoud, and I would like to invite Danish with us, big boss, our guest of speaker, Dr. Danish. And our speaker, the first one, it will be Christian Meyer. Yes. So today it's my best surgical video. We'll have a 4-minute presentation, then we'll have a 4-minute for discussions.
Okay. Thank you very much. So I will start by a video that actually I got last night because I really got a shock. My fellow sent me this video because he had an Osidex implant that was fallen into the anterior chamber, and I was not there, and I recommended him a maneuver that we did a year ago, and I want to show you this in advance. So it's just a 30 seconds video. You see, can we elevate the tone? There's a tone also available. So he's, and you would hear his Austrian accent. So this patient, he just talked to the lady to look up and to look down, and you see how he can manipulate the Osidex implant. So there was an opening in the iris at 11 o'clock, and you can see how he was positioning it here. So this was already close. I was amazed when I saw this last night, and you can see that he's manipulating the Osidex to the hole. Now you see he's at the edge, and now you see that within 30 seconds it's again in the vitreous cavity. So he was lucky that that this implant was at the posterior pole. But now I want to start with actually my video, but I think that was really worth to show you at this time. So this was also an emergency case I did with my fellow a couple of months ago in Davos. So he was a constructing worker for the ski slopes, and he got a foreign body into his eye. What I noticed that there was really a very tiny opening in the cornea and in the anterior capsule. So my fellow said, well, let me do the phaco. And I said, oh, it would be a pity if we really would damage the anterior capsule. So I got reminded of my fellowship when I was at Duke with Cindy Toes, and there the vitreoretinal surgeons, they performed cataract surgery from the posterior part, so they removed the lens. So my goal was in this eye to maintain the anterior capsule, so when you later have to inject silicone into the vitreous cavity, that you have a plane, a cleavage plane between the anterior and posterior pole, and you don't have silicone oil that's coming anterior. So you see very nicely the anterior capsule is still in place. You see the huge rupture in the posterior part, so I assume that the foreign body came to the cornea, to the anterior capsule, and then it started spinning in the lens, and luckily it also went to one, not into the center of the macula. This was a young patient, and we started vitrectomy, so it was really difficult also to detach the vitreous from the retinal surface. So I used a pick to release it. I don't know why it's not so sharp in this case. And there you see, so luckily at the arcade there was the fallen body in the retina and in the sclera. And after I did a meticulous cleaning of the periphery, because I think this is very important, especially in young patients. We added 360 laser just to secure it, and before I extracted the foreign body, as Ferenc Kuhn taught me, we applied laser around the foreign body. Also to avoid bleedings, we added now some Dicaline to seal the posterior pole, and then we removed the interocular foreign body. Initially, we tried to also to remove it to the anterior part, so in order not to dilate the sclerotomy, but this was too difficult, and so when this happened to my fellow and it fell down we didn't want to, we want to avoid it in a second place, and we removed it to one of the sclerotomy. We enlarged it, and afterwards I injected silicone oil into the vitreous cavity just to be on the safe side in this patient. He was a young patient, and I was fearing PVR reaction because this was a huge trauma that was going through the retina, through the choroid, deep into the sclera. The silicone oil was filled up to the anterior capsule, and by the end we even were able to implant an IOL into the quote sulcus, because the posterior capsule was still, it was a young patient, so it was a very stable situation, and we were able to, as you can see here now, to implant an IOL. We were capable to do an IOL master prior to surgery in this eye, and we also can compare it in the calculation with the fellow eye. So this really went well. And my major concern was that he would develop PVR in the post-operative period. So this was 8 weeks afterwards. You see some scar formation basically on the anterior capsule, on the opening towards the anterior segment. We didn't have any prolapse of silicone into the anterior chamber. And what I also learned from my chairman, Peter Kroll, that it's quite easy in these eyes to remove the silicone oil by just making one sclerotomy to aspirate the silicone oil, and you can use anterior chamber maintainer for the infusion. After we removed the silicone oil, we also added additional laser and an ILM peeling because we saw that after surgery, yes, there was a good vitreous detachment achieved, but still there was some mild epiretinal membrane formation in place, and to be on the safe side, we also removed this after the silicone oil removal. And so here I show you the OCT prior to the OCT, the oil injection, the oil aspiration, 8 weeks after surgery in the horizontal OCT, and this was 4 months after the silicone oil removal in this young patient. We were able to achieve a vision of 20/50. Thank you very much.
Hi, thank you very much for such a lovely video and certainly very challenging cases. I just noticed that I might be wrong. You put the silicone oil first, then you put the intraocular lens. Is that right?
Yes.
I mean, why is that? Because normally it's not so easy, and normally you put the lens in first.
I know. It was quite a stable. Well, you know, if you put in the silicone oil and you already have a tunnel, that may be difficult. And in this case, the capsule, the anterior chamber was so stable. I mean, otherwise I would have done it in the opposite direction. You can also do it, but I mean, we never had silicone oil in the anterior chamber because it was just a tiny opening. I don't know.
And what was the strength of the silicone oil? Centi-stroke, was it 1,000?
5,000.
5,000. Okay.
Now we'll go for the next case. Thank you so much. Our next case will be presented by Dr. Amar Farid.
It's opened already. Okay, thank you. Good afternoon, everyone. Thank you, Dr. Amri, for inviting me for this meeting. Today I'm going to speak about one case. It's okay? So this is a female patient, age 42 years old. She's diabetic. She presented with decreased vision. It's not stable. Okay. She presented with decreased vision in both eyes. She's diabetic since 20 years. She is now controlled. She had cataract surgery in both eyes. She had vitrectomy in the left eye since 1 year ago. And she has a counting finger 1 meter in the right eye and hand motion in the left eye. The pressure was okay. Anterior segment was unremarkable. This is the examination of the right eye. As you can see, there was an epiretinal membrane with traction retinal attachment in the right eye. Left eye, this is after surgery. She has also an epiretinal membrane with hemorrhage and a big hole in the retina. As you can see, this was under silicone oil. So I decided to make a surgery for her to fix the left eye first. It's quite a long surgery. Started with the removal of the silicone oil, then trying to remove the PVR and the epiretinal membranes from over the retina. There was still some silicone oil under this big hole, and it was sucked through this hole. As you can see, this is the second wave of removal of the silicone oil, and we're starting to remove the epiretinal membranes. As you can see, there was extensive epiretinal membranes all over the retina, extending to the far periphery of the retina. I make it quite fast because it's a long surgery. But as you can see, we're trying to remove the epiretinal membranes step by step and very meticulous, and we don't take your time in these cases to remove all of these membranes because it is done before, so you are not sure what's left from the vitreous before. Then the second step after this was to do some trimming of the left vitreous in the periphery. As you can see, there was still some vitreous in the peripheral area. And also searched for, the decision was made to to start using both hands or to use my bimanual technique to remove some of the membranes, attach it to the hole, and attach it to the subretinal areas as well. Trying to clear all the PVR from the surface of the retina. There was also some subretinal membranes as well, and then it was a trial to make for air fluid exchange to try to put the retina back in place. As you will see now, This was the trial, but as you can see here, there is some air under the retina. It means that the retina is too short that you cannot put it back. So I decided to make first the ILM peeling, and after we will make the posterior for inferior retinectomy. So I started to put the stain and then do the ILM peeling. It took quite some time also because the retina was detached, but it was managed at the end. In these cases, of course, it's very important to do the ILM peeling because you're expecting if you left it, you will have more and more PVR after and more epiretinal membranes. Then the next step was to do the retinectomy. So through the hole, extended the hole a little bit, and we continued to do retinectomy to the inferior half of the retina to release every traction in the retina and put it back. As you can see, the retinectomy now is completed. Then you put some PFC to put the retina back in place. The edge was cleared from any rolled edges. The retina now is stable in place with no traction over it. Then endo laser was done to the retina, and of course we have to use silicone oil in these cases. So silicone oil 5000 was used in this case. The retina now with the lamp is back in place.
Give to him this one because that one he is moving his.
And silicone oil at the end of the surgery. So this is 2 weeks after the surgery. The vision improved actually to 0.2 for this patient. And 6 weeks after the surgery, there was fine a little bit of epiretinal membrane. I don't know, I think you are hearing me. Okay, do you hear me now? All right. So the vision improved a little bit to 0.3, and this is the OCT. You can see also that there is thin retina, but the vision was okay. This is here after 1 year from the surgery, and the silicone oil was removed, and the patient with the vision completed to be good to 0.3 and with a stable PDR. Thank you so much. Yeah.
Removal of the silicone oil, did you remove the residual membrane which was there at the posterior?
Yes, I removed this membrane at the time of the removal of the silicone oil, but luckily when you do this, the ILM peeling was very important, otherwise this membrane would come over the macula. So it's a very important step in these cases to remove to do the ILM peeling, of course.
Yeah, and I think true stability only comes when you remove that membrane and remove the silicone oil. Yeah. Till that time you're not sure whether you're stable or you're not stable. It could detach again unless you remove that membrane.
Yes, yes, I removed it as well.
Great case.
Yeah, thank you so much, thank you.
You did most of this work under air, including the ILM peeling?
No, under fluid. All
because
of it
there was
under
air, or you put it back again?
No, under fluid. All of it was under fluid.
The retinectomy was under air?
Yes, the retinectomy was under fluid. No, I went back, of course. Okay. It was just a trial to do air fluid exchange to check if the retina will go back in place or no, but when we found the air going under the retina, I went back to fluid and then continue the surgery, of course, not under air. Okay. No.
We'll move on to the next video, Dr. Hassan Bahrani. Dr. Hassan.
Sorry about the typo mistake. So how do I move forward? It's a video. So this is a case of, it's a family actually of multiple patients of same family. So this patient presented in 2021. He underwent multiple sessions of laser retinopexy for multiple retinal capillary hemangiomas. Actually, all of them resolved except for this very large one. And so he had a macula-threatening TRD, and what I did for this patient, he's a 13-year-old patient, and of course in these cases you have to make sure you have to delineate and remove all the hyaloid. was presented with this very tight fibrotic membrane over the retinal capillary hemangioma. And I was wondering that I have to remove this capsule for the retina tube. But then while I was doing that, I encountered this very severe fetal vessel hemorrhage. So then I kind of thought maybe it's better just to dissect around it, shave the vitreous hyaloid. I cauterized the fetal vessel in this case. And then I went on lasering the retinal capillary hemangioma and being conservative in the first case. And then while lasering, those fetal vessels are very prone to bleeding. So anyways, we cauterized this again, and I was able to achieve good hemostasis with this patient. And that was the end of this first case, and I injected some anti-VEGF. But post-operatively, he came back with vitreous hemorrhage and inferior RD. So I had to go back again. Obviously, it bled from the same fetal vessel. This time, I had to kind of make sure that I do, I guess, more aggressive management, peeling the ILM, fovea-sparing ILM membrane peeling. And when I checked the case, there was no way this retina was going to be flat with just leaving it that way. So I cauterized all the fetal vessel, and I went at the edge of the fetal vessel, and I decided this time that I needed to do retinectomy to flatten this retina. So I went around it, and there was very thick, viscous subretinal fluid underneath this obviously chronic retinal detachment. And then I proceeded with end retinectomy of this retinal capillary hemangioma. I think the first surgery was helpful in making sure that I have limited bleeding intraoperatively in the second case. There was a lot of subretinal fibrosis, subretinal bands. Here I got another bleeder this time. Of course, you have to do everything similar to your regular retinectomy cases, making sure you have to shave all the interior retina, all the hyaloid. I think I paid too much attention to this area and maybe didn't take too much attention to the nasal retina. So silicone oil, of course, in this case, and he did actually quite well. And then so he was healing quite well. And then on his silicone oil removal case, I noticed a nasal RD. So I did a barricade laser retinopexy, and I proceeded with. So that was kind of good because centrally he was fine. This pathology was peripheral, and I proceeded with just making sure I peel all and I always peel before I do any retinectomy, because sometimes you see the membrane here is extending beyond the retinal detachment area. And at this point, I decided, of course, to do the retinectomy to this area. It was a stable RD. And then I also did chorioretinectomy. And I have a lot of experience doing a lot of foreign body cases and doing chorioretinectomy, and they just do so wonderful, actually. So in this case, I went ahead and I did the chorioretinectomy. This is just a very extensive fibrotic membrane. I will also shave this RPE or residual pigments, which is the scaffold for possible future PVR formation. So this is the chorioretinectomy. And the wonderful thing that the retina was stable, so I didn't have to worry about that. And a fluid air exchange, silicone oil, of course. He did have some cataract, posterior subcapsular cataract, but thank God my work was perfectly at this point. So he's doing very well, actually. Thank you.
That was a great video, very aggressive surgery. And that's actually the problem with these angiomas, because they have a lot of anterior traction. So would you consider an alternative of putting a buckle in the first space and doing cryo of that area? Because after you've removed the traction, first of all, it's difficult to remove that traction completely, but it's, as you said, it's more extensive than it looks. It's sometimes on the sides, it's a lot more than it looks, and that's why it can take time to settle. But putting a buckle in that entire quadrant can actually, and then doing cryo for that lesion can actually help you to get a more lasting...
very good point. Actually, when I was intraoperatively, the second case, I was thinking about that because I saw a lot of fluid, and then, you know, it was a little bit posterior, to be honest. It was not a peripheral retinal capillary hemangioma. It was a little bit close to the posterior pole, maybe at the edge of the posterior pole. So I think it's a call that can go both ways. It's a call that can go both ways. Having a buckle, I think I do a lot of buckles, so I'm prone to do buckles. And maybe if in this case, I wouldn't, you know, I have a 240 buckle. So maybe a 276 tire buckle would have worked amazingly for this case. So retrospectively looking at this, that probably would have been the best option. A 276 with a 240 band. Yeah.
Thank you, Dr. Hassan. This is very, very nice surgery, actually. We have not bad number of those cases. And what we notice is the patient, surgery is difficult, but the issue is the PVR post-op. And what surprised me is the PVR came even after buckling. So I start doing what he proposed of start with the buckle. Then the PVR came a lot, so I get obligated to do what you do at the end. What we should understand is buckle can help on compressing the retina, but it will not close the von Wipple disease or the retinal hemangioma that you have it. So either you have cryotherapy, as you said, and will bring us back to the more BVR later on. And this is what happened in some of our cases. One of the suggestions is to have a black therapy from behind. So it will cause shrinkage and atrophy and ischemia. The other option is like some Turkish people do. They suture the feeding vessel.
Yes.
Yeah, but and we have tried that also. Really? And suturing is wonderful surgically, but the issue is when you close a vessel, there will be congestion in the area behind it, so you can get the bleeding behind. This is why, if you make me a choice, I will choose cautery rather than suturing, because cautery, it closes the vessel, but if the pressure increases, it can leak a little bit somewhere else. When you do suture, you are really closing a very wonderful vessel that can have congestion and leakage beyond. There is some also study show that, and some case report show that there is a chemosis post-op. Whenever you do buckling for those cases, and you will get surprised. You will get surprised in some cases when you dissect to do the buckle, that the vessel abnormality is not only inside the retina, it's around, outside. And I think this is maybe why, how we can explain the BVR and the inflammation post-op. Some of the case reports show that you can have like an ecchymosis post-op. And this will bother the patient a lot. But it was wonderful, wonderful act, Dr. Hassan. Thank you.
Thank you. That was very interesting.
Yeah, I welcome the next speaker, Dr. Saad Wahib.
Okay. Okay, so I'm going to take you off the younger patients. This is, I call this the unfortunate patient, and you'll see why in a few seconds. This was a 50-year-old healthy female who is a regular patient of mine. She came to see me with floaters and flashes in her right eye of 1 week duration. She had, same patient, she had an RD surgery done by me 12 years ago. And she was doing very well in this eye. She's otherwise medically healthy. Her vision at that stage was 20/30 in the right eye, the eye that she's complaining of. The left eye, this is the eye that we have done 12 years ago. Anterior chamber was normal. She had left pseudophakia, normal IOP, and at that stage she has an acute PVD with a vitreous bleed in that eye, and the other eye was very stable. So I told her that this is a PVD, she needs to wait, we will observe it, her retina looks good. She comes back after a week with a dense vitreous hemorrhage in the same eye, but the B scan showed no RD. After 2 weeks, the blood started to clear. She was very happy, but then a week later, she came with drop of vision, hand motion vision, and a macula of retinal detachment. So, you know, as you would expect, we decided to go for surgery. You can see here the old vitreous hemorrhage inferiorly, and she had a macula on supratemporal detachment with a nasal horseshoe tear. You know, just a usual standard phakic RD that you would usually do. So we did the usual. We flattened the case, and I think I used SF6 gas, and for the just sake of time, I'm just gonna continue. So you can see the supranasal single hole. There was an area that looked suspicious inferiorly that I laser. I don't routinely do 360 unless I have a suspicion. So she did very well. Vision improved. Gas was starting to disappear. The bubble disappeared. Her vision came back to 20/60. She was really happy. But then on the 5th week, she came back to me with a disturbed vision. And then when I looked at her, she had a macular hole. So I reviewed all the videos and I looked through them, but I couldn't see anything. You know, she had a reasonably large 600 micron hole. Her vision dropped to 2200. She was not really very happy because she was comparing it to the other eye. And I said to her, listen, it's rare, it does happen, you know, and sometimes it relates to tangential traction or some, you know, macular cyst happening, but it's gonna need surgery. So we decided we were gonna go for surgery. I took her back. We did, you know, the usual again. I put some triamcinolone to make sure I'm not missing any vitreous, and the vitreous was very clear. And, you know, we did, you know, the usual. And in a second, you'll see that I stained, and I usually re-stain. And I did an envelope, macula sparing envelope technique, which went very smooth with her. Restaining is key in these cases. So the usual, you restain. I'm doing the inverted envelope to try to cover the area, and everything went fine. I have a good technician. I usually take an OCT within a couple of days after the surgery, and I put air in her case, and the hole looked closed. And everything was going in the right direction. She kept face down for maybe 2 or 3 days, and we were going in the right direction. But then she came back on the 15th day post-op again with some blurriness of vision and discomfort. I looked at her. She had a hazy vitreous, a lot of cells. I wasn't sure if this is infection or vitreous hemorrhage. I told her to come back after a few hours, and it was a full-blown endophthalmitis with, you know, not, you know, fibrin and massive AC reaction. So since the fact that she had 2 vitrectomies before, I decided to tap and inject and give her a steroid. She did extremely well, and, you know, the condition stabilized. She's 3 months post-op. The hole is unfortunately open again, and it's much bigger. but her condition is stable, her vision is 20/200, and at that stage, I asked myself what to do, because I started to become very suspicious of such a patient. So I asked a very good friend of mine, and he said, you send her to your best friend. Don't touch her. And then she's a good friend, a patient herself is a good friend. She kept on coming to me, and we were talking about it. And then I was co-managing a patient with another senior friend of mine who said, why don't you consider a temporal flap? It might work. So I brought the patient, I discussed it with her, I told her, and she took some time. She came back to me, she said, I'll let you do the surgery under one condition, do not video my surgery. Somebody told me that it's the video that caused all of that. So I said, fine. I did not video her surgery, and to my surprise, she's done very well, and alhamdulillah, she's stable until today with a vision of, I don't think her vision is going to improve much around than that, but really, every now and then you will encounter these patients, very unfortunate patients, but I think there's always a way to deal with them. Thank you very much.
Thank you so much. It's a wonderful case and very eventful. The most importantly, how you have managed it. Okay. So my first question: when there was a vitreous hemorrhage, did you induce PVD?
No, I'm sorry. Did I what?
Did you induce PVD on the first surgery?
Did I use what? Sorry. I'm sorry. I can't hear you.
Posterior vitreous detachment.
Did you induce? Oh yes. Yes. I mean, in her case, I think it was partially detached already. But yes, I mean, you do the. I didn't show the whole video because this. I mean, this. I think the interesting point here is not the surgery. I mean, these are routine cases. But the consequence of events that happened, I couldn't. I mean, it has been reported macular hole post, primary vitrectomy for retinal detachment, but it's just rare. I haven't seen a case like this.
Yeah. Neither me I have seen in my cases. The next question that when you did an ILM pill when you plugged your macular hole, the first surgery, did you selectively just plugged it from the nasal side because you still had an ILM flap on your temporal side when you do the second surgery?
Oh yeah. I don't do big ILMs. I'm always worried that I might have to come back. So I do usually a limited envelope technique. So what I did in the last surgery is I went really temporal, and I started the flap temporally, and I brought it. I made sure the distance is long enough so it will cover. That's the idea behind the temporal flap, because you start at the periphery and you bring the flap, you make sure you have the right distance, otherwise it won't reach. Okay, but I don't do an extended ILM, not in the primary surgery. Some surgeons go arcade to arcade. I don't, because I'm worried it might come back, and that's why.
Yeah, wonderful case. Difficult to explain why you had the macular hole on the first go, which is 0.3%.
Yeah, I agree.
Sorry, just a comment, going back a little bit, do you think when the patient presented with significant loss of vision with vitreous hemorrhage, although the retina was attached on the B scan, you should have intervened then? Because nowadays, the concept of intervening early in case of PVD or partial PVD related vitreous hemorrhage is more dominant than waiting for the retinal detachment to occur. So if you have intervened at that point where there was a significant vitreous hemorrhage without retinal detachment, the things might have been different.
Well, if you look at the timing, she didn't give me a lot of time. I mean, initially she was improving, and then she came with this, and we waited only for 2 weeks, and the hemorrhage disappeared quickly. But the thing is that when it disappeared, she detached immediately. When I saw her originally, she was macula on. She had a supranasal temporal, but the macula was on. Would I have intervened earlier when the vitreous hemorrhage was there? I don't usually operate within 2 weeks. I like to wait a little bit, because most of the times they clear, and then you can see the tear and you laser it. I did tell her that in the presence of vitreous hemorrhage and a PVD, there's a very high chance of a retinal break, given the history of her other eye. So I was expecting this, but Yeah, I don't know if going early would have helped.
How did the end of resolve? What did you do for the end of?
What did I use for what?
For the endophthalmitis. For the endophthalmitis, you said the
Oh,
patient...
just antibiotics, inject. I did not do a vitrectomy, just tap and inject.
And then you waited for this to resolve. It resolved with just an injection.
Yes, yes. Ahmed, you had a question.
Actually, it's a great case. Just a quick comment. Sometimes it becomes a social embarrassment taking the patient back and back to the operating room. For example, this example, and also like vitreous hemorrhage or vitreous cavity hemorrhage rebleed in diabetics. One technique which works is air fluid exchange, or in this case would be a air fluid gas exchange in the clinic, like C3F8. And I had a couple of cases that closed with just putting gas in the eye. It's just something to save the social embarrassment.
Yeah, she didn't give me time. She kept on coming with problems. So I hope she
So
stays stable.
retrospectively, everything is possible. I think we do what you think is good for our patients and ourselves. So may I invite our next speaker, Dr. Thanasis, to deliver his lecture, and we are all eager to hear you, sir.
I would like to thank you for letting me be here. It's really a pleasure. The thing that I would like to share with you is how to transfer this knowledge that you all distribute, and to show you a selection of videos later after that presentation that is done by fellows, that they selected pieces of nice didactic tricks and tips, that's the next thing we do. So we decided in Thessaloniki, which is a small port north of Greece, to do something like training people with different aspects, like complicated cataract surgery. And the guy you see in the middle is Carlevale. So Carlevale is bringing 50 lenses. We bring 50 people, and Carlevale teaches himself how to put a Carlevale lens. The next thing is you see the setup that we need to have. Not to be different than any operation theater. You need to have a microscope that is down there with wheels and everything to imitate exactly the name of the theater. And this is how many machines you need to have. That's a Stork, that is Constellation, that's everything to imitate exactly what they want to do in the theater so they can have the same setup. The thing that people don't understand why we do that is because of the social economics. If you see this, you say, we have to be democratic. Everybody's going to do one exercise. Please jump on the tree. So it's not the situation for everybody. If you have machines, if you have technology, if you have everything. Social economics are very important for each country, how to regulate his correct way of doing things. And the other thing is how to introduce technology, the new technology, to people who don't have access to the new technology. Because the new technology happens from the representative. The representative comes and shows you the ingenuity, not the well-known guy who knows how to do it, not the doctor. You see Ahmed from Canada, he's teaching us how to make complications easy. And this is the trick of the whole wet lab. No pig eyes anymore. You cannot make a vitrectomy wet lab with pig eyes because there's no viewing. You cannot do an ILM. You cannot do retina detachment. So we have these bionic eyes which are reusable, and you can do all these things together. and also introducing new technology of Ingenuity, because with Ingenuity, the combination of ILM, of retina detachment, is much easier. So we had 5 Ingenuity systems while doing it. And this is how we transfer knowledge from generation to generation. And this is the setup we have. This is the setup of the theater, and this is the Huxrite new system to train people. And the next one is going to be between July 3 and 7 in Thessaloniki. So the next thing I would like to show, that some of the people here that I had with me made a selection of my previous videos. Don't save. And that was it. And this selection of the previous video were done so I can speed them up to have a didactic issue. For example, sorry, I have to go back. This is a case that we have a giant tear. I always believe when you have a true giant tear, you have to do the cataract. You have a clear lens here. So I do a clear lens extraction because on the periphery, you cannot work for a giant tear with a lens in your way. And you can see that's the didactic point of this. You don't do vitrectomy in the peripheral. Sorry? Oh. Sorry. I was so absorbed with what I was seeing that I didn't see the result. It's playing here. So I'll come to each one of you with the laptop and I'll show it separately. Well, it's crazy because the last one, I tried to avoid to upload it.
Which one video?
Which one? Yeah, you have to go back. Now I don't see my video. But you see it, it's much better. I don't see anything here. But here you can see, it's confusing, but I'll try to do it. You can see when you have a giant tear, how to put perfluorocarbon fluid while you're using another fluid needle to remove to have the current of the flap to go back. So there's our tricks and tips. Now I cannot control my presentation, which is horrible because I thought I can control and go forward and backward, because I cannot control my presentation anymore. And next time I will not bring an apple for the presentation. I brought this. Horrible. You're not going to enjoy that. Okay, let me stop. Let me show you here. You have a bullous detachment. And in bullous detachment, one thing we can do is to empty the bullous detachment by doing vitrectomy at the hole by using scleral depression. So if we have both hands and a light, extra light, you can go and suck all the fluid by doing scleral depression because you remove all the tension of all the floppy retina is now under your scleral depression and is not moving. You immobilize the retina this way so you can remove all the fluid and you can see all the, and this is just diathermy. And I don't know what to say now. I have to stop. I have a few more, the normal drop nucleus that you use manually, because I cannot go faster. Can you do something about it? It's my laptop? Is it? Now I can see it, you cannot see it. I have to stop here because I respect your time. Oh, there it is. This is that you don't want to leave anybody without a treatment. This is a patient that has two eyes, and one eye have, the projection was not certain that he can have any vision. After 6 months of retinal detachment, they say you cannot have any result, and they gave up for the patient. So we did the retinal detachment, although he has no actually perception of light. And we did all the retinal detachment. And we used clarity pressure again. This was a horrible eye when I see it. But when we did that, at the end, we used silicone oil and did the cataract and everything. Just to tell you the story, now we're using a new system that everybody can use. That Med1 is making an infusion cannula. You can use silicone oil, 5,700 to do the injection. So this trick and tip you can have an infusion that can inject silicone oil. And you can do it by manually, in the same time, removing perfluorocarbon and injecting silicone oil and flattening the retina at the same time. But with this system, the infusion, the silicone oil infusion of Med1, you can see that you can put pressures like 60 to 70, not millimeters, but you can see how strong it can be. We're pressing, and the 5,700 is sticky there. And if you close that lumen, it still doesn't go off. And this is the problem, the infusion. These are new tricks and tips that we have and involve all the time. I'm sorry to stop here. I cannot go on because I have so many small things that I needed to go fast to show you one after the other because I made a connection of that. But this is what I see, nothing in my laptop. And this is diabetic. But never mind, the last one. Can anybody from there can do it faster? Can do it for me faster? No, because you don't have the presentation. I'm stuck. Can we stop here? Sorry. I don't want to spend more of your time. Okay, thank you very much. The idea was that it's another story to give a lecture, it's another story to do surgery and to train somebody, it's another story to tell people to go to the internet to see what's going on, and another story for a teacher to say all the tricks and tips you cannot find in the internet. So this is another issue of teaching people. Thank you very much for accepting me.
Thank you. Yeah, may I request Dr. Ahmed Al-Barki to present his case?
Thank you. Hi, thank you, Muhammad, for inviting me for this meeting. Can you play the video, please? Just a little introduction, that's it. A few seconds. My case is about trauma case, actually. Little suspense only, not more than this. So it was a challenging case, at least for me. Trauma, very big trauma. Male patient, global resection, very big, I will show it now. And the primary repair was done. And as you see here, how big the laceration extended both sides of the sclera. And on the nasal side, extended like more 7 meters. So B scan was done. This was done 2 months later after the surgery. And you can almost close funnel there. And you see the cornea now, this is the best cornea we can have, so that one of the challenge here is the poor visualization. We go inside, there is no place to put the infusion, so we put AOC maintainer. I tried to go with the parsiplana, but there is no access. You can see a lot of blood behind the iris, so I do what you can say paracentesis vitrectomy, not parsiplana vitrectomy at this stage, because I need to go from the paracentesis side port with the vitrectomy probe, trying to release the blood behind the iris, give access to the infusion, so later on I can do the vitrectomy through the pars plana. As you see here, when you go inside, you find like a salad of tissue. It's vitreous, blood clots. You don't know where exactly you are, poor visualization, but you start to try. I've tried to very peripherally try to remove the blood clot as gently as I can, because in my back mind there is a closed funnel detachment there. So definitely I will do retinectomy in this case, but I don't want to do it accidentally. I hope can I do it intentionally. So I start to very peripherally make sure this is a blood, because sometimes with this long duration cases the retina could be there. So I like to digging superficial, so starting from anterior or behind the iris and going back, trying to find the plane at any time, and then it can start. So as you can see here, just trying to remove the blood as much as I can, very gently. It takes long time with me, so after maybe 30 minutes or later, or more than that, I can now visualize the retina there, and you can see how it's stretched and very difficult. Now there is a space to both the infusion in normal position now. So I go, there was subretinal blood, which is expected because of the massive trauma, we are expecting that. The good thing that we didn't have choroidal hemorrhage in this case. I remove the blood, already there is some retinectomy was done. Complete the vitreous peripherally, trying to get more part of the retina to visualize. There is just a blood clot behind the retina. I removed that. And while doing that, I discovered there is an incarceration on the side. As I showed you the very picture, there was a big nasal wound. So during suturing the initial circular wound, there was retinal incarceration, was expected in such kind of difficult case. So the only reason, or the only way now to do 360-degree retinectomy, we cannot do that at there is a site where is the incarceration there, perfluorocarbon to flatten the retina. And for sure, it's expected because of the long duration, retina was stretched and fibrosed. So you do peripheral vitrectomy and you find that you have small retina there, but still we can do that. So after that, we put in air, and with the back flush needle, I'm trying to flatten the peripheral retina as much as I can. I want to get more retina as much as I can. And after that, put silicone oil. I cannot do laser under air because of the visualization, because poor cornea and air, it's make difficult. So I do the laser under silicone oil and do a 360-degree around the remaining retina in this case, and do laser all around. And now then you can have flat retina. Let's say part of the retina for sure. It's not the whole retina, but this is what you can do that. So we have intraoperative OCT, so I want to make sure that the retinas or macula is on. So fortunately, I was lucky that the macula was on intraoperatively. I just put some viscoelastic because this patient is aphakic to prevent the migration of the silicone oil. And that's the end of my case. Thank you so much.
Thank you, Dr. Ahmed, and congratulations for your new company, Retina.
I cannot hear you well, by the way. Sorry for this.
You can hear me?
You need to come here.
Yeah, the echo is not good. Yes.
I'll talk?
Yeah.
Okay. I said congratulations for your company.
I thought you were asking a question. Okay, thank you. Thank you.
And congratulations for the surgery, because it's so bad case. I have a question for you. Did this patient have a contraction on the edges of the retina which you have cut later on?
Come again, sorry, I cannot. Remove the mask. Let me talk.
The retina retracted after?
Sometime?
After the surgery, after the follow-up, you mean? Yeah, the follow-up. Actually, the retina, it's remaining there. It's very small. And actually, I keep following up for 6 months because of insurance issue. I cannot see him again. But during the 6 months, everything was okay. So, but I am expected. This is a good point to be retracted because it's a very bad retina. You can see it during even if you look at while doing retinectomy, there is no bleeding. I didn't need to use the thermy the retina was very, ischemic and rigid. So I am expecting to get more contraction. So
Yeah, most of the time when you have a chronic funnel or post-trauma, and especially on your nasal side, if you see the retina becomes thickened and they don't open up. And you might see during the surgery that you see the laser effect, but the laser actually doesn't affect and cause a chorioretinal adhesions.
Yes.
Those are the ages we try to contract later and pull the retina, especially in your case. But it's very good that 6 months is doing well. Congratulations.
Thank you. Thank you so much.
I invite Dr. Muhammad for his unexpected culprit.
Thank you, Dr. Muhammad Al-Amri, for this kind invitation. So I will go quick through two videos. The first case is a 55-year-old male with diminution of vision of 3 months. He has poorly controlled diabetes mellitus, and the vision in the left eye is counting finger 50 centimeters. Basically, it's cataract in the left eye with dense diabetic vitreous hemorrhage with no details. I did B scan of the left eye to discern whether there is a retinal detachment or not. So just vitreous hemorrhage, no retinal hemorrhage. It was just straightforward vitreous hemorrhage case. We went for surgery. I thought it's a walk in the park. We are doing just diabetic vitreous hemorrhage. Started the case, as we can see here. Again, I cannot control the video. Anyway, as you can see, I started after doing core vitrectomy. I started to see this swelling, this rounded swelling at the superior arcade with the edge encroaching upon the fovea. So I just wanted to stop here and ask the panelists, what do you think of this swelling? Sorry for this.
Yeah,
it's a dome-shaped swelling.
Yeah.
Just discovered. It's not appearing on B-scan pre-operatively. Okay? Sorry, but I have no control on the video from here.
Yeah.
So I started to think what this could be, and we have all those bad thoughts of this swelling, what could be. Here, after completing vitrectomy, I just wanted to, yes, there is a fibrovascular stalk on this area, a diabetic fibrovascular stalk on this area. I cannot stop the video.
Is it a perforation?
No, it's a traction. I think it's a. No.
So, yeah. Yes, here I tried, after I finished vitrectomy, I tried to pull on this. There is a hole over there. Can you see this hole? There is a little bit. It's a perforation by the peripalpar nerve. Thank you, doctor. Thank you. So it was I tried even to do laser around this hole, is not taking laser, increasing the power of the laser, is not responding. So all this mold is a kind of fluid under the retina. I tried to, during the fluid air exchange, to drain from it. It's just subretinal, subchoroidal, and I just surround it with laser, doing the rest of surgery. This is the fluid air exchange. And macula is not affected. I put silicone oil just to give it. And here after 5 days, we can see disappearance of the whole thing and my laser marks over there. So it is a perforation with a peripalpar injection. We'll just stop here. Yes, sir. Yes, I don't have this cannula. I could find this. So this is an unexpected thing. I thought it is just an easy case, diabetic vitreous hemorrhage, and it is an in-house. Our anesthesiologist, very much experienced in peripalpar injection. Thank God it was away from the fovea, so it ends up that the vision was excellent post-operative. And I'm preparing to remove the silicone soon, inshallah.
Was there the hemorrhage on the first post-op day after phaco?
I did phaco and vitrectomy. So the first post-operative day, this is one. The second case, this is the second case. This is my second case. This is referred from outside 1 month after phaco. 1 month after phaco. And she's telling me, I don't see with this eye after surgery. She has dense vitreous hemorrhage in the left eye, and the B scan again shows vitreous hemorrhage and no retinal detachment. Here I saw the IOL. The IOL is in place. Excellent surgery. There is a corneal opacity, central corneal opacity bilateral, and in this case, I suspected it is a perforation. So this is the picture. You can see here the corneal opacity. Not sure if it is playing. Yes. As you can see here, the anterior segment is an excellent surgery. IOL in place, well-centered, posterior capsule is intact, and very dense vitreous hemorrhage. So one month after. So I went to do first I did with the microscope, then I went inside removing this very dense vitreous hemorrhage. And I remind you that the B scan of this patient showed no retinal detachment, just a very dense vitreous hemorrhage. And here you can see this is the rest. I'm trying to remove the rest of the, and here I started to discern one linear tear, and next to it there is a small round tear. So there are two tears, one linear, this is the linear perforation, and one round small perforation next to it with subretinal hemorrhage, again away from the fovea luckily away there. There is no retinal detachment, however, and this is another case of, and it is not a retrobulbar, it's a peribulbar. So I completed the rest of the vitrectomy and put silicone oil. Unfortunately, this patient vision didn't improve. So here is a kind of comparison between two cases. The first case is an in-house peripulbar injection, no retinal detachment, and it is extramacular tear, and I did immediate pars plana vitrectomy, immediate. Whether the anesthesiologist did inadvertent injection or not, I did immediate. Visual acuity improved. The second case, external, unknown, could be retrobulbar or peripulbar. I know the center where they are using peripulbar mostly. No retinal detachment extramacular. There was 1 month delay in pars plana vitrectomy, and vision didn't improve significantly. So I suspect that there is a chemical toxicity to the retina after injection. Anyway, this is the points to consider. We have to consider the perforation. We have always to maintain a high index of suspicion of globe perforation. Peripulbar anesthesia incidence of globe perforation is 1 over 16,000, while retropulbar injection is 1 over 10,000. So peripulbar is not very safe, rather than, so because many people believe that peripulbar has no complication or perforation is less. No, you can get perforation. These are the predisposing factors we are all aware of: high axial length, posterior staphyloma, uncooperative patient, deep set eye, multiple attempts at entry, and inexperienced surgeon. And you can get all kinds of complication, and the intraocular injection of the anesthesia can cause both chemical and mechanical. So if you keep injecting, there is a report of globe perforation, globe rupture. Suspect another tear. 40% of eyes had more than one retinal tear. 70% of eyes with attached retina at the time of perforation achieve good prognosis, and the presence of retinal detachment most probably develop PVR, and this is associated with less favorable prognosis. Thank you very much.
Did you do the OCT of the patient to see why the OCT, fluorescein angiography, to see why the vision did not improve?
I suspect because there was no retinal detachment. The two tears are away from the fovea. I suspect chemical injury or chemical.
Yes, so that would show up in the, either there'll be disc pallor.
Sorry?
Either there will be disc pallor or there'll be some effect on the macula.
Effect on the macula or
So
the
did
optic
you do
nerve?
the OCT?
Not sure.
Because the other important thing, and I think that's for everybody to know who gives the peribulbar, people have a tendency to move the needle to see whether it's inside. But actually, that's when this kind of linear tear occurs.
Yeah, and the second case showed that the surgeon or the anesthesiologist has went one time, then retracted the needle and went with the other time.
Yes.
In this way, it did one linear tear and the other.
The second time is when he.
And the second time where he injected through this small perforation. This is what I suspect.
And just a quick comment also for the peribulbars. One of the anesthetists I worked with, he raised a very good point. He said normally when we ask the patient to look up when they're injecting, they tend to look towards their forehead. If they look towards their forehead, the optic nerve and the fovea becomes more closer to the track of the needle. So it's very important to make sure that you ask the patient not to look up, but to look straight.
And my point that many people take the peripulbar injection lightly, and they think since they are injecting outside the cone, it's safe. So you have to look for signs of perforation, especially when you are going with the needle and the cornea starts to move towards you. If the patient feels pain, if there is some pressure while you are injecting, you have to suspect, you have to stop, not to inject. Just go out and try some other place for anesthesia or postpone or whatever. Thank you very much.
So we welcome our next speaker, Dr. Abdullah Al-Qatani, for his lecture.
Interrupted shoots well, sir. The ideal thing in primary repair is to maintain a firm pressure and to maintain AC with good firm pressure. And here we close our peritomy. And we actually do a lot of, we start by giving her a subtenon injection of steroid. And she passed her post-operative uneventfully. And for that, she had a vitreous hemorrhage. You brought her after 4 weeks for secondary surgery, planning to do a lensectomy because of a lot of adhesions and synecdoche. I start with 2 pores only. Then I remove most of the cataract lens and iris, synecdoche, and a lot of things to visualize the retina first. At this stage, we classify as type 1, a blunt trauma with rupture, non-violence, as I said, zone 1. And because the vision is only perception, it's a grade 4. And she has a positive afferent pupillary defect. And I put my second third cannula for pars plana to complete the vitreous hemorrhage. As usual, unfortunately, the retina is almost, but you can see the myopic degenerative changes. We remove our cannula and we put also another injection of steroids. She came about 1 month ago. We advised her to go to contact lens for her pseudophakia, and she regained a good vision till now. The retina is on. This is also to say that although when we start to seeing how it looks very bad prognosis, but if you go directly to repair and you wait for the nature to come and can do secondary surgery, removing the vitreous, and this has value. Thank you very much.
Thank you very much, Dr. Bakr. Very excellent surgery. Certainly very, very challenging. So in these kind of cases, as you rightly, waited for 4 weeks, what is the optimal time you think to intervene in case that the retina on the B scan remains attached? So what is the optimal time?
As I said, her post-operatively went very eventually because then I do it just for to relieve some of congestion of the eye and to make it quiet and not to do surgery in a congested eye with a lot of inflammation and these things. It is.
Yeah, thank
Nazimun.
you. No, post-trauma, I think you need to wait until the posterior vitreous detachment occurs, then probably you can go in and operate.
Posterior vitreous detachment, she has already had that.
Post-trauma, immediate, you can go
BVD,
with
yes.
Or otherwise, within 2 weeks, you can go in. Within 2 weeks.
2 weeks, actually, she is staying far away, actually. She came from more than 200 kilometers. So she has to return back home and they have to gain some money to come back for the surgery, second surgery.
Good job.
Last time I saw her, she had a contact lens and she had a very good vision. Thank you. Dr. Subata, this is my mentor, actually. I'm very glad this meeting to see Dr. Subata after a long time.
Yeah, thanks, Abu Khair. He was our first fellow from Sudan, so I'm really proud. I think the way you sutured that, I was so happy because you sutured with the Jovanovic technique without incarcerating the vitreous. But only one thing is there, that if that vitreous hemorrhage is attached to a corneal wound, then we should go early because the corneal wound contracts and it causes a detachment earlier than the vitreous adherent at the vitreous wound. And this is what Ferdinand Kuhn and other trauma society members have taught us, that if it is attached to the cornea and you have vitreous hemorrhage and attached retina, go early. If it is attached to the sclera, you can still wait because that doesn't contract like the corneal wound contracts. So excellent surgery and great work.
I want to say that with such bad prognosis, sometimes we give it to the residents or the resident to do it. I think it should be done by the senior vitreoretinal surgeon in such cases.
Okay, thanks. Okay. We move on with the next speaker.
Thank you.
Dr. Mohammad Naeem.
Well, thank you for having me here, and it's an honor and privilege to present to you. These are some of the pearls of the TRD. This is bread and butter of where I come from, Bahrain. So this is a case of 50 years old female. She was a known case of diabetes, hypertension, hyperlipidemia. They were uncontrolled. And status quo, she had left eye combined surgery for TRD. And these are the credentials. You can see in the right eye is the eye that I'm going to operate on. It's a hand motion. She had significant cataract, poorly dilating pupil, and no NV eyes, luckily. But in the left eye, where she presented to me, surgery was done somewhere else, and she had, unfortunately, no perception of light. She was pseudophakic, the IOL is in place. She had afferent pupillate defect and florid NV eyes all in the anterior segment. These are the picture of the left eye, 1 month apart. Still the vision maintained, no PL, and she had a lot of membranes underneath the silicone oil, and there was no scope of rescuing this eye. So this sort of scenario just puts extra pressure at the back of your mind because now you're dealing with a middle-aged female with a uniocular circumstances. Can we just have the video, please? Okay, so it's a combined surgery. Just before the surgery, I given this patient intravitreal bevacizumab because in my experience, when you provide them with the injection, it sort of reduces the intra-op bleed and it reduces the time of the surgery, and then you use less endothermy, less amount of inflammation. I had to use retractors because the pupil was non-dilating, And sometimes even I start them in this retractors, you have to be very sure that in diabetics, they tend to have postoperative exudative membranes. So I tackle that at the end of the surgery by giving them subtenon Kinacort. So this is some tips that you need to do if you're dealing with the combined surgery. So this was my first glimpse of the retina. You see the whole retina was detached. And usually I start my vitrectomy in such cases in the mid-periphery because that's the only place where you have the scaffold. So retina is a little bit, gives you some space to make the vitrectomy, co-vitrectomy. And then I go for the peripheral vitrectomy, and if the peripheral retina is attached, then I do the PRP before engaging the central membrane. Now this is the high resolution. First, I try to find all over from the 360 degree a place where I have a scaffold, I have a space to engage and start doing my segmentation. My aim is to go and find the optic nerve. Here, as you can see, I'm just guessing where would be my macula and optic nerve. And unfortunately or fortunately, the groove that I had was just above the macula. So I had to be very sure. The moment I realized that I'm dealing with the fovea region, I just increased my cut rate to the maximum and the lower vacuum, because on the macula I don't want to induce any holes. So in that region you have to just do that, and then you do what I do usually is radial membranectomy. From the optic nerve you go into different directions. This way you minimize the chances of inducing posterior pole breaks, because you want, the retina is taut but still it has a resistance. So you want that retina to have resistance. And now I just have a look at the edge where the membrane ends, you have the peripheral retina starting. That's the area where usually the retina is extremely thin, and you have to be very careful dealing with that area. But I use that break in my advantage because I had a subretinal blood. So I use that break to just aspire the retinal blood, which I would have done retinotomy to remove that blood, because epiretinal blood is all right, because I don't like to leave subretinal blood, because it just somehow oozes back to the macula. And then you just, any island of the membrane that you find is extremely thin and very strongly adherent, you just leave it to the end, because you don't want to induce breaks in the beginning of your surgery. You just leave it to the end, and you can always come back to them later and deal with them after we have put the heavy liquid. And this is usually the technique I use. I just use certain settings and try to peel off the membrane. I use my cutter here. The reason I use 23 gauge, because I was anticipating that I might be putting 5,000 silicone oil. And the second, because of the thick membranes, the cutter is very effective, 23 gauge. And then at a certain stage, I use forceps, because there are schools which tell you that for TRD, the use of forceps is forbidden. I don't believe in that. It's just you should know that when to use them and how to use them, and you need to be very careful. When you're pulling the membranes, you have to look at the retina, and you just know where to stop before inducing any breaks. So this is what I've done here, and the moment you have made a groove, or you have made enough space for your cutter to be introduced and do the remaining of the cutter, so this is what has happened. So then you just remove the rest of the job. If you see here, there's bleeding, because this case is like very uncontrolled diabetic, and previously so many injections and no laser has been done. But giving the pre-op bevacizumab helps you control a lot of bleeding, together with sometimes you just need to raise the air fluid level. So the moment you finish up cutting these membranes just with using the cutter, you will feel these are the edges that you have to be very careful, which is at the end of the membrane and beginning of the peripheral retina. Then I just use the PFCL, because now I'm going to deal with a inferior area of the epiretinal, the fibrovascular membrane, that I found it to be extremely adherent and very thin. So you had to go very carefully there, and already I induced one break there, and I think they're going to be one more. So I was lucky enough to get away with this case with just 2 iatrogenic breaks, and I used those breaks in my advantage, and they were quite away from the center of the macula, so I was not worried about them. And then only in this part, I worked centripetally instead of going all the way radially toward the peripheral. So at the end, it's just in my favor. I did fluid air exchange, and I removed the PFCL, and later you'll say, here what I do, my technique is that I put IUL, before doing the AF fluid exchange. I don't complete my, because somehow I don't feel comfortable doing the peripheral vitrectomy with the edge of the optic. It somehow gives me diffraction when I'm focusing. So this is just the way I'm comfortable doing it. There are people who do the phaco and they put the IOL in the beginning and then they do the posterior segment. But I'm just very comfortable in this approach. So just before the fluid exchange, I have done the IOL insertion, viscoelastic removal. I'm done with the anterior segment. So again, back to the posterior segment because the same machine that I'm going to use, the Centurion, the Constellation, sorry. So the first thing I'm going to do, I have 2 electrogenics brake. I'm going to secure them. Before I jump on my laser anywhere else, I'm going to make sure my 2 brakes are totally flat and well lasered. After doing that, now I have enough time to go and play around in the peripheral part of the retina because it needs very good laser. Because initially when the patient was not properly controlled, she did not have PRP, so that makes my job. So she will gonna need a lot of laser. So then I put 1,000 silicone oil because case didn't require 5,000 in my opinion. And I just sutured it, and just make sure when you suture, you tighten them very well using the 2 forceps because otherwise you don't want to end up with subconjunctival silicone oil bubbles. So this is one thing that you keep in mind. And the post-operatively, you will see I followed her up now about 3 months, but I have the visual acuity. It started from counter finger on the first day. It improved on the 5th day. Only thing you will see that there are clots of the pre-retinal hemorrhages. That with time would change its color because of the deoxygenated and eventually it will get absorbed in the silicone oil. So the main idea is that your fovea has to be on and your retina has to be flat and your brakes have to be flat. And you have done good peripheral shaving. The moment you have done that, I think I mentioned all these spurs during my presentation. Only the last thing that I would like to emphasize that dealing with the mononuclear patient, it puts an exert pressure psychologically on you, but you should not leave hope and never give up on the patient because patient's hope is attached to your hope. And thank you for being a wonderful audience. Thank you.
Yeah, thank you, Dr. Mohammed Naeem. This is a wonderful case, and actually it's a difficult case with a broad-based traction. Okay, it's a broad-based traction almost going up to the equator. So I would just tell the salient point, which I felt was good, is that you made some island of removing the traction. You made islands of those fibrous proliferations. And while you're pulling and doing the dissection with your cutter, you were radial and towards the retina rather than pulling it because these areas are so ischemic. So when you pull and you dissect, you might cause a linear tear. Okay, and in your case, in the periphery, because it was a chronic detachment, you see the retina in the periphery is very thin, and that's the edge between the fibrous proliferations and the non-fibrous area, which is thin. That's the area difficult to dissect. And that's the area you may create multiple breaks. So a job well done, but some may even argue, so why not use a bimanual technique? So I would say whichever you are comfortable in doing that works good in your hands and the endpoint is met and that is the criteria. So whichever works good for you. And you have done a good job. Thank you.
Thank you for your comments. Regarding the bimanual, usually I refer to it when I'm stuck. So we use PFCL when it's needed and then the second stage. But in this scenario, not always after COVID, we have a good enough supply of all the consumables. So that's one thing that affects your decision.
It was a great job. It was a tough case. 2 tips. You had a stage when you had the the nasal periphery of that membrane visible. That's the easiest point to use to to separate out the membrane from the retina. So if at that stage, if you use a forceps to just come circumferentially along the edge of the membrane, you'll find it works very easily to separate the membrane. As Nazimul said, bimanual, and I would say specifically when you got the detachment in the superior area, that's the best time to shift to a bimanual. That would help. And one last tip, when you were talking about getting the plane, I found that if I use a 25 gauge sharp needle, the MVR, and use it to make a cut in the central area. There's always some space there, and you can easily create a plane between the underlying retina and this membrane, and then you can separate it out further, and then you can cut it further.
Well, thank you so much for your both points. Regarding the first one, I already tried that, but because the surgery was 2 hours, I had to make it in 5 minutes. I didn't mention all the tricks. And second, I'm usually a little bit reluctant in using the needles because I got these valve trokers. So the moment I'm going to use the needles, I'm going to lose that quality of the valve. So I sometimes, while later on I'm going to need, so in combined cases, I use that when I'm left with no other resources. Those are lovely tips. Thank you so much.
Okay. May I welcome Dr. Mohammed Taufik?
I will present a case of combined traction and remedial attachment diabetic. After injecting this eye 2 days before the surgery with anti-VEGF, I started working with the case by doing what's called vitrorexis, separating the anterior vitreous from the submembrane. And when I complete the job of vitrorexis, I put a bubble of PSC to act as a third hand supporting the retina when I'm working by manually to attack the membrane by a forceps in left hand and the scissors in right hand. And this is the point of trimanual vitrectomy, as I call the trimanual vitrectomy, because the PFC now act as a third hand supporting the retina, that's a detached retina, and help me to have a gentle traction by the left hand over the membrane and go with the scissor to cut the epicenter. And we have also here a small tip. When you go with this such a curved blunt scissor, make a dissection of the membrane rather than cutting the membrane to decrease the incidence of bleeding from cutting the membrane with the scissor. So if you go with the scissor closed like this and searching for the epicenters, if you are succeed to cut the epicenter by dissection, not by cutting, it's okay. If you feel that it's a stucky epicenter, go ahead and cut it. This technique help you to decrease the incidence of bleeding when you are when you are working under the membrane. And another thing here, the PFC make the bleeding is less, like a hemostatic effect of the bleeders. So if you have a bleeding after cutting the epicenters or the blood vessels, it's helping the bleeding to a little bit hemostatic. As you can see, we are approaching over the disc and there is a sum of bleeding, and also it's a little bit controlled. So again, when you gently traction by left hand, go closing the forceps, the scissor underneath, and try to search for epicenters while you are closing the scissor to cut it. So if you are fail to cut with the scissor closed, open it and cut it. So that most of the job is done while the scissor is closed. And this type of the scissor, the tip of the scissor is blunt. So you don't feel when you are going underneath the membrane to injure the surface of the retina. And also see how beauty the PFC supporting the retina while you are grasping with the left hand. If you are not using this technique, you need to use a very gentle maneuver by your left hand because the retina is detached, and when you are just separating or gentle pressure on the surface of the retina by the fibrovascular membrane, the retina is welcoming with you, and we don't have such a beautiful support when you are working on such a membrane. And again, we are starting in the lower part. I close the forceps, the scissor, and go also by a blunt dissecting of the membrane, trying to decrease the attacking of the membrane by cutting the membrane, not by dissecting it. I will a little bit moving the video for sake of time. Now I succeed to remove the membrane, the one membrane. And again, at the one membrane, and I remove it by the cutter, remove the rest of the membrane like this. And this is also another point. You didn't need to remove the BFC if you need to decide to remove the ILM. Inject the stain under the BFC and also remove the ILM under the BFC. And all this time, the hemostatic effect of the BFC and the supporting effect of the BFC help you to finish the posterior pole job and complete the anterior job also, like vitreous indentation and vitreous shaving. Leave this bubble at the end of the surgery and remove it after you finish the surgery. Thank you.
Excellent, beautiful work. Really liked it, and a super trick. Just quick question to ask that how much vitrectomy was done before you when you introduced the heavy liquid, or you started with the heavy?
We start with what?
How much vitrectomy you had completed before you put in the heavy liquid?
Oh, the technique of trimanual vitrectomy. How much the technique? No, I don't have the exact number.
You've done the vitrectomy. You did the vitrectomy.
How much the vitrectomy? So I complete the vitrorexis, separating the posterior membrane 360, totally 360 from attachment of this membrane to the anterior vitreous. Because if you are putting the BFC and there is still connections of this membrane with the anterior vitreous, the job is difficult here. Because you need a free anterior edge of the membrane 360. So with attacking the membrane in all the clock hours is a free anterior edge. So it must be complete 360 vitrectomy, separating all the membrane from the anterior vitreous.
Very good.
Dr. Ahmed.
That's a great case, well done. Just a very quick comment. Usually when you cut, you're crushing the vessels, so actually bleeding should be less. Blunt dissection, you're avulsing the vessels, so bleeding should be more. But I mean, it's beautifully in your hand, but I just want to stress on this point that crushing the vessels while cutting actually decreases bleeding.
When you cut, decrease the bleeding?
Because you're crushing the vessel with the scissor, so it decreases bleeding.
Yes.
Yeah, I mean, blunting is easier to find the epicenter, but that's like more avulsing the vessel. But again, what works in your hand is beautiful. Thank you so much.
Thank you.
Did you ever use a spatula?
Yes. Yes.
So, would you prefer using spatula than rubbing with the
I think that's all fine. I mean, he makes it really look very easy. It's fantastic. But I was trying to stress that when you cut with the scissors, you're actually crushing the vessels, so bleeding should be less.
Thank you. Last question I want to ask you. Is there a limitation to this technique?
Yes.
I mean, the limitation in the sense what Mohammed Naeem has shown that case. Will you use the same technique to do that case?
No. It's a limitation if you have a obvious break when you are doing this surgery. I tend to do the regular bimanual surgery, first thing. The second thing, if the membrane is a little bit smaller membrane, you don't need to do this job. Make it, if you are failing to separate the posterior membrane from the anterior vitreous, I would never do this BFC, because if you have a shortening retina and you are not separating the membrane and freeze the posterior pole from the vitreous, when you put the PFA bubble, the retina will be shortening and will not flat posterior. So it's not as a mandatory for all the fibrovascular membrane.
Thank you. So I welcome our next speaker, Dr. Ahmed, please.
Hello. So I would like to share with you my plan for extreme closed funnel cases. So this is a plan. That means it should be reproducible. That's why I put it into words for you. So this was a trauma case, 10 years old. He had repair a month ago. I usually use 2 chandeliers in these cases so as to illuminate the upper and the inner side of the retina. And then I first remove the anterior PVR or the flaps to get on with this job. Then I let loose the retina if it's vertically tense upwards so as to be able to work because if it's vertically up, I cannot work properly. That is, if I choose to attack the retina from outside of the closed funnel, not from inside. But I chose here to work from outside first because I saw the napkin ring and the thick PVR outside of the cone, so I chose to do it from outside. If it's attached all over and it's a closed hole, it's a closed funnel, so I start from the center. Then I use a double forceps technique to remove the PVR and shear open the peripheral contracted edges of the closed funnel, so as to open it, so as to get access into the funnel to remove the PVR, especially this stalk of PVR attached to the disc. And if you remove this stalk, the closed funnel will open up a little bit. So after opening up a little bit, I inject a bubble of PFC so as to stabilize the retina and go trim the contracted edges. I have to trim the contracted edges because I have tried to leave them and laser over them, but they always contract more and lead to detachment after that. So I shear them open, I trim them by the cutter, and I do diathermy over them, but I freshen up these edges. Then I reposition the retina at the right rotation and put some PFC, not so much so as not to topple over the retina. And if it's still contracted, I do multiple radial cuts to increase the these usually increase the circumference of the retina. If you do a radial cut, this increased circumference increase the retinal circular circumference, and it can flatten. I use as much as I can radial cuts, as much as needed. Then I stain all over the retina under the PFC to see if there is still PVR left. And I usually do the ILM, not for the sake of the ILM, but to make sure that the PVR is removed from over the retinal surface. And that's usually it. I do the laser barrage, and I put silicone, and then I use the dual option of the injection aspiration to remove the rest of the PFC, and that's it. Thank you. Any questions?
Yeah, wonderful case.
Thank you.
And very beautifully delivered. I feel that if you can keep a hinge of the retina to one side, then possibly you can avoid post-operative cyclotorsion, because sometimes your macula may be a little bit torsion down or up. Okay, so keeping at one hinge, and while you open up, you put the bubble of PFO.
You mean if there is a part of the retina, just one or two clock hours,
yes,
you leave it?
Keep it? No, just for the posterior one to sit. After that, you remove it for you.
You cut it.
Okay.
Yes, of course. That's a good,
yeah,
a very good point. But sometimes this hinge makes the retina still upwards and
yes.
And prevents it from going flat.
Yeah, that's why only to get the macula right in place, because many times.
That's a good idea.
Yeah,
I'll put it in the plan.
Yeah, so many times you have to use a long soft tip to shaft the retina to move, because that's what we used to do translocation.
Yes.
Okay, we used to have a lot of problems.
Very nice idea.
Which we gave up. Okay.
Thank you.
So I think you did a very wonderful job.
Thank you.
And well done.
Thank you.
Mohammed, do you have a last word about the case?
Thank you very much, Dr. Ahmad. Thank you for all of you. We are sorry to keep you until this time, but I think everyone sitting here, they are enjoying what they are seeing and discussion. We are going to meet at 9 o'clock for gala dinner for a speaker. It will be in the swimming pool, just here near to our ballrooms outside. Yeah, if someone wants to swim like Dr. Usman, he can come. Thank you very much and see you tomorrow, inshallah. There is an early morning for Arabic, those who want to attend Al-Qahwa, very interesting sessions. And tomorrow it will be, I think, medical or surgical, Dr. Muhammad, tomorrow. Right. Yeah. So see you tomorrow. Thank you very much. Thanks a lot. Good night. Bye-bye.